Welcome to another edition of T-Cell Case Presentations. My name is Dr. Elaine Husney. I'm a rheumatologist at the Cleveland Clinic, and it is my distinct pleasure to introduce Dr. Scott Plevy, a gastroenterologist at the University of North Carolina. He's in the Division of Gastroenterology and Hepatology. His research interests includes how interactions between the immune system and the environment lead to initiation of the inflammatory response in IBD, or inflammatory bowel disease. Today, we have the opportunity for him to take us through a very unique case of a young woman with inflammatory bowel disease. And in doing so, we'll review T-cell biology, highlighting both the inflammatory and anti-inflammatory T-cell subsets, specifically looking at TH17, TH1, and the role of Tregs in promoting homeostasis as well. This will have great relevance to other inflammatory diseases that we all study as well, including multiple sclerosis, rheumatoid arthritis, lupus, or diabetes.
Hi, this is Dr. Scott Plevy from the University of North Carolina School of Medicine. Today, I would like to take you through a case presentation of a new diagnosis of Crohn's disease. Importantly, I would like to use this case to illustrate the importance of T-cell responses and some basic concepts of T-cell biology in the pathogenesis of the human inflammatory bowel diseases. As you will see, the topic of my discussion is going to have broad relevance to other chronic inflammatory diseases that you treat in your practices as well. So let's start right in with the patient. This is a 28-year-old woman who presents to the emergency department with recurrent abdominal pain. The present episode began yesterday with the onset of diffuse lower abdominal pain. She describes a cramping sensation which was not localized, with waxing and waning of this pain, which became severe at times and increased this morning. Her last bowel movement was yesterday in the morning. She's been nauseated since the pain started but has not vomited. She particularly noticed that flatulence has decreased, and in fact, she has not passed any gas today. In the past month, the patient has had two other episodes of similar abdominal pain that lasted several days each. During the second episode, she was admitted to an outside hospital and was determined to have a small bowel obstruction based on abdominal X-ray films. These symptoms, however, resolved, and she was released 3 days ago when the pain resolved and she clinically improved after essentially having some bowel rest and going on a liquid diet. Her past medical history is significant for laparotomy for an ectopic pregnancy 8 years ago. She noticed the recent development of aphthous stomatitis, which she dates back at least several months, with the occurrence of oral ulcers in her mouth, which her physician told her were herpetic in nature. She had an episode of a red eye, which she was told by her primary care physician was episcleritis 8 months ago, which spontaneously resolved. She seems to recall receiving eye drops for this, which may have helped. She also has developed arthralgias of the knees, ankles, and elbows, which has significantly limited her activity and exercise over the past 6 months, and she associated an increasing sense of fatigue with the fact that she hasn't been able to work out like she normally has. So I'm going to interrupt the case presentation at this point with a question. I already gave you the punchline in terms of diagnosis with this case. This is going to be a case of Crohn's disease. So before we go into how this was determined and what the significance is in terms of immunology and immune responses, let me address the issue in particular through this question of this patient who had an episode of episcleritis, aphthous stomatitis, and had developed fairly diffuse arthralgias, which had interfered with her quality of life. And the question is, which of the following statements about extraintestinal manifestations of IBD is incorrect? A, inflammatory conditions affecting the eye, joints, skin, and liver occur in up to 25% of patients with inflammatory bowel disease. B, coincidence of immune-mediated disorders with IBD reflect common genetic backgrounds. C, genetic pathways involved in immune-mediated disorders and IBD highlight the role of T helper 2 or TH2 cells, and D, genetic pathways involved in immune-mediated disorders and IBD highlight the role of TH1 and TH17 cells. So I'll give you a second to think of what you would answer this question, and now let me tell you what the right answer is. The incorrect statement of these four is C. Genetic pathways involved in immune-mediated disorders and inflammatory bowel disease highlight the role of T helper 2 cells. The correct statement is about the genetic pathways involved is statement D. Genetic pathways involved in immune-mediated disorders and IBD highlight the role of TH1 and TH17 cells, as I'll illustrate. The other two comments are correct. Inflammatory conditions affecting the eye, joints, skin, and liver occur in up to 25% of patients with inflammatory bowel disease, highlighting that inflammatory bowel disease is in fact a systemic illness, and also highlighting the fact that many of the immune manifestations that you deal with in your practices across inflammatory diseases may be driven by the gut, and the coincidence of immune-mediated disorders with IBD do in fact reflect common genetic backgrounds. So, just to briefly review some of the data supporting the answers to these questions. There are many extraintestinal manifestations that we see in inflammatory bowel disease that could affect up to 25% of patients. We see inflammatory skin disorders, perhaps most prominently erythema nodosum and pyoderma gangrenosum. There are ocular disorders, including iritis, uveitis, and as in our patient, episcleritis. There are hepatobiliary inflammatory conditions, including sclerosing cholangitis, which actually can progress to cholangiocarcinoma. And there are joint disorders, including peripheral arthritis, sacroiliitis, and in fact, full-blown ankylosing spondylitis. Unlike the last slide, where I showed you a list of extraintestinal manifestations of inflammatory bowel disease, there is actually an impressive coincidence of other inflammatory disorders that many of you may see in your practice in patients with IBD. I'm summarizing a population-based study of over 8,000 inflammatory bowel disease patients out of Canada. This study revealed an increased incidence of arthritis, asthma, psoriasis, as well as multiple sclerosis in patients with inflammatory bowel disease. The prevalence of arthritis, in fact, in ulcerative colitis was 12%, and in Crohn's disease, 6%. The specific diagnosis of rheumatoid arthritis occurred in 1.6%, higher than in population controls. Interestingly, 63% of IBD patients had a diagnosis of another chronic inflammatory disease, which antedated the diagnosis of inflammatory bowel disease. So let's relate this to pathophysiology. And what's interesting is with the explosion of genetic data and the sequencing of the genome, we have learned that there's a shared genetic underpinning of many of the autoimmune and inflammatory disorders that we all treat in our practice. And you can see here that inflammatory bowel disease shares genes with virtually every other important and prevalent chronic inflammatory disease that we see in our clinics, including multiple sclerosis, rheumatoid arthritis, lupus, type 1 as well as type 2 diabetes, and asthma. So there are common genetic signatures and patterns that ultimately direct the disordered immune response that we see in all of these conditions, and many of these are shared amongst the diseases that we all treat in our practices. Let's delve a bit deeper into the genetic associations that have been found in chronic autoimmune and inflammatory diseases, highlighting the important T cell subsets, TH17 cells and TH1 cells. Is my ultimate goal for this talk is to provide an overview of T helper subsets and their role in the pathogenesis of IBD. Many genetic associations that have been found across inflammatory diseases involve signaling pathways that are instrumental for the development and sustenance of TH17 and TH1 cells. To give you several examples, genetic polymorphisms in the IL23 receptor have been found to confer susceptibility and resistance to inflammatory bowel disease, both ulcerative colitis and Crohn's disease, as well as psoriasis and ankylosing spondylitis. Looking at signal transduction events in the T helper 1 pathway, we see that receptor defects in the specific IL12 receptor beta 2, predisposed to not only inflammatory bowel disease, but a chronic disease of the liver, primary biliary cirrhosis, and defects in downstream signaling molecules such as JAK2 are involved in the pathogenesis of inflammatory bowel disease as well. So these are two highly important pathways, not only for the development of inflammatory bowel disease shown through genetics, but other chronic inflammatory diseases. Well, let's get back to our patient now. On physical examination, the only salient finding was in her abdominal exam, where she had moderate tenderness diffusely in the lower abdomen. There were diminished bowel sounds. There was no guarding, rebound tenderness, masses, or abdominal distension. She came into the emergency room taking some pain medication, which was prescribed at the outside hospital, but nothing else. As is often the case in patients with abdominal pain, in the emergency room, a CT scan was performed. And I'm showing you images from the CT scan on this slide. And you could see the dramatic and salient findings in the patient's right lower quadrant on these 4 images. The first thing that you notice is that there's a segment of bowel that has grossly thickened bowel wall in the right lower quadrant, with a paucity of air visualized in the lumen. If we follow this segment of bowel more proximally, you see that all of the small bowel proximal to this is markedly dilated, and this is consistent with an intestinal obstruction. The pattern of disease seen here in the terminal ileum, which is the most common location affected by Crohn's disease, is pathognomonic, if not diagnostic by itself, for Crohn's disease. The patient was subsequently admitted to the hospital with an intestinal obstruction from presumed Crohn's disease, and colonoscopy was performed. Colonoscopy revealed an inflamed ileocecal valve, and due to inflammation, the terminal ileum was not able to be intubated. Biopsies from the ileocecal valve revealed the picture shown on this slide. There were dense infiltrates of inflammatory cells, and what you see in the center of both of these pictures is a loose collection of nuclei known as a multinucleated giant cell, and I will discuss the significance of this subsequently. So, reviewing the patient's hospital course, the patient was made NPO and started on IV methylprednisolone, 50 milligrams every 8 hours. There was no improvement in the patient's pain, and she was not passing flatus over the next 3 days. She was consulted on by surgeons and was taken to the operating room. At the time of surgery, she was noticed to have an extremely inflamed terminal ileum and cecum, which was resected, and pathology revealed the cecum had chronic active colitis with transmural inflammation, mucosal ulceration, and focal granulomatous change consistent with Crohn's disease, as did the ileum. On the next slide, I'm showing the actual surgical resection from this patient, and I'd like to highlight the fact that the patient's terminal ileum, shown on the left side of the slide, has evidence of an extremely thickened bowel wall. You can see 2 large dark furrows within the terminal ileum, which represent deep ulcerations, and you could also see a thickened cecum shown on the right side of the slide. In contrast and comparison, if you look at the very left side of the slide, you can see that the resection margins look actually normal, and that's what a normal ileum would look like, with these normal tan folds and a non-thickened bowel wall. Histopathology from the surgical resection, first of all, revealed a dense mixed inflammatory infiltrate within the lamina propria of both the small intestine and the cecum. What you're seeing here are multiple blue dots surrounding the epithelial crypts, and all of these blue dots are cells of the immune system. And in fact, the majority of the cellular infiltrate represents activated T cells. If you look closely, you could also see neutrophils and other inflammatory cell infiltrates as well. But there's an awful lot of T cells here, and we're subsequently going to address what these T cells are doing and why they're there. On this surgical section, what was also seen was several of the features shown on this histopathological slide. And what you're looking at here is an area of multiple nuclei in the center of this picture that represents multinucleated giant cells. You can see the large nuclei, and this is surrounded by a dense aggregate, almost that's circular in nature, that's comprised of both T cells and B cells, and this is a granuloma. And the granuloma is a specific indication of a type of T cell response. So, based on this, the next question is, granuloma formation is most characteristic of what type of T cell immune response? A, T helper 1 or TH1, B, TH2, C, TH17, D, T regulatory or Treg, or E, none of the above. I'll give you a second to think about what the answer may be. And I will tell you now that the correct answer is A, T helper 1. So granuloma formation is the histological hallmark in people and in animal models of a T helper 1 immune response. So let's use this as a point of departure to review T cell subset biology and their physiologic and pathologic significance. As a reminder from your basic immunology overview, antigen-presenting cells are important to direct T cell development, and they do so through three signals. When we talk about antigen-presenting cells, again, the two most common that you'll hear about are dendritic cells and macrophages in that order. B cells can also subserve this function as well. Signal 1 is where the T cell receptor on a naive CD4 positive T cell recognizes its specific antigen in the context of an MHC molecule. For CD4 positive T cells, the MHC molecule expressed on antigen presenting cells is MHC class 2. This signal is necessary for activation, but signal 1 alone is not enough to get an activated population of proliferating effector T cells, and you need a second signal for this to happen. The second signal is what we call the co-stimulatory signal. The most common molecules expressed on the surface of antigen-presenting cells that deliver the co-stimulatory signal are members of the B7 family that bind to cell surface molecules such as CD28 or CTLA4 on the cell surface of T cells that give signal number 2. This leads to survival and proliferation of activated T cells, and this is really necessary to get sustenance of an effector T cell response. What we're going to discuss subsequently and review from your basic immunology lectures is signal 3. And signal 3 is a soluble signal delivered by cytokines to activated T cells that direct the development of naive T cells into certain T cell, important functional T cell subsets. These are the TH1, TH2, TH17, and T regulatory subsets. And we're going to discuss how exactly this happens, number one, and then we're going to discuss the importance of these subsets in Crohn's disease. So signal 3 for T cell subset development is important to understand, as these signals are, number one, important therapeutic targets in the clinic, and number two, are highly involved in the biology of human health and disease. There are three inflammatory T cell subsets that we'll go through first. There are the TH17 cells, the TH1 cells, and TH2 cells. TH17 cells differentiate through a signal 3, which is comprised of the cytokines TGF-beta and IL-6. TGF-beta and IL-6 direct the expression of the TH17 signature transcription factor, ROR gamma T, which then drives the subsequent expression of the signature TH17 cytokine, IL17, which is how these subsets got their names. T helper 1 cells differentiate in the presence of IL12 and interferon gamma. IL12 and interferon gamma induce the TH1 signature transcription factor TBET, and this allows the production of the TH1 signature cytokine interferon gamma mainly, although interleukin 2 is another TH1 specific cytokine. TH2 cells, which are involved in allergic and atopic diseases, are induced in the presence of the cytokine IL4. IL4 drives the expression of the TH2 signature transcription factor GATA3, which results in the expression of the TH2 cytokines interleukin 4, interleukin 5, as well as interleukin 13. There is one anti-inflammatory T cell subset which is very important in human disease, known as T regulatory cells or Tregs. Interestingly, Tregs differentiate under the presence of TGF-beta, so this is also required for inflammatory TH17 cells, and we'll get back to this. TGF-beta leads to the expression of the T regulatory signature transcription factor, FOXP3, which is necessary for the expression of the anti-inflammatory effector molecules that determine many of the functions of T regulatory cells and their ability to suppress inflammatory responses, TGF-beta and interleukin 10. Well, moving on to some of the signals, signal 3 that, as well as a more downstream signal that I call signal 4 for TH17 development that are highly relevant in human diseases of such as inflammatory bowel disease. Let me briefly review the biology of interleukin 12 and 23. Interleukin 12 and 23 are heterodimeric cytokines that share a common P40 subunit. Interleukin 12 has a unique P35 subunit, and interleukin 23 has a unique P19 subunit. Interleukin 12 is signal 3 for the development of TH1 cells that make interferon gamma from naive CD4 positive T cells. Interleukin 23 isn't necessary for the development of TH17 cells, but actually has an important sustenance role in the development of TH17 cells. Interleukin 23 is necessary for the sustained production of the TH17 specific transcription factor ROR gamma T, and therefore the subsequent production of interleukin 17, which is the signature TH17 cytokine. So I like to refer to interleukin 23 as signal 4 for TH17 development. It's not necessary to get a TH17 cell, but it's necessary for their sustenance. The importance of IL12 and IL23 is that therapeutics geared towards blocking these cytokines have already infiltrated the clinic. Anti-IL12 P40 antibodies, which block both IL12 and IL23, are FDA approved in psoriasis and have shown success in phase 2 clinical trials in human Crohn's disease. So this is an extremely important therapeutic target that you're going to be hearing much, much more about, and probably has some of its major prominent effects on its ability to block the TH1 and TH17 pathways in human disease. So moving on to the next question, we talked about how these inflammatory and anti-inflammatory T cell subsets develop, but what is their function in health? And in order to understand their function in disease, we have to take a step back and ask what these cell types do normally. So the question is, TH1 responses are most involved in host defense against A, intestinal helminths, B, extracellular bacteria, C, intracellular bacteria, D, viruses, E, all of the above. I'll give you a second to think about this. And now I'll tell you that the correct answer is that TH1 responses are most involved in host defense against C. intracellular bacteria. Granulomas, which is the histologic hallmark of TH1 responses, is also the histologic hallmark of intracellular infections such as mycobacterial infections. So TH1 cells have evolved to really aid the body's host defense against intracellular bacterial organs. Just to review the functions of these other T cell subsets, TH2 responses are most involved in the host defense against intestinal helminthic infections, intestinal parasites. TH17 responses have evolved to aid in host defense against extracellular bacteria at the skin and mucosal surfaces. In terms of viral host defense, you've learned that it's really CD8 positive T cells that are most intimately involved in host defense against viruses which reside inside of cells due to their ability to recognize viral antigens expressed in the context of MHC class 1. Well, that's some of the physiologic functions of inflammatory T cell subsets. Let's take a step back and talk a little bit about the role of an important anti-inflammatory T cell subset, T regulatory cells, and how these may be extremely important in the pathogenesis of inflammatory bowel disease. On this next slide, I'm showing you a normal histologic section from a human colon. But what's normal in the gut is not normal in other organs. And what you can see here is that the lumen is at the top end of the slide, and this is where billions, literally, of microorganisms normally reside and have learned evolutionarily to live at peace with the gastrointestinal immune system, which is the largest immune organ and contains the largest number of immune cells in the human body. The bacteria and microbes in the gut lumen are separated from the cells of the immune system, which are represented by all of these blue dots shown in the lamina propria, by a single cell layer of intestinal epithelial cells, which are themselves, in fact, immunologically active. So here you have the biomass of microorganisms in the gut lumen, which in fact outnumber the human cells in our entire body by somewhere between 10 and 100 to 1, coupled next to the largest immune organ in the human body. And you ask yourself, well, isn't this an accident that's waiting to happen? Well, the immune system in the gut has evolved to recognize invaders and pathogenic organisms that enter the body through the GI tract, and for reasons we don't clearly understand, know how to respond against pathogenic bacteria and microbes. But point in fact, in normal physiology, the vast majority of antigens and microbial products that the mucosal immune system, the intestinal immune system, is going to encounter are innocuous. So everything we eat in the diet is going to pass through the epithelium and get absorbed into the body. There's going to be microbial products and actual microbes leaking through the epithelium on a regular basis, and the body needs to know that every time it sees a microbial product or a dietary antigen, it doesn't need to react. So therefore, all of these blue cells we see in the lamina propria, the vast majority of them are actually T regulatory cells, which are there to actually shut off active immune response and to promote homeostasis and to promote anti-inflammatory responses against innocuous antigens that we encounter the vast majority of the time. So T regulatory cells play an important role in inflammation and normal gut physiology. This is perhaps best illustrated by mouse models of inflammatory bowel disease. And there is a particular mouse model where immune-deficient mice who lack T cells and B cells, if we give them an activated effector population of T cells, they develop inflammatory bowel disease due to the accumulation of autoreactive T cells in the lamina propria. This disease can be treated by the transfer of a CD4 positive, CD25 positive, FOXP3 positive T regulatory cell population, which then homes to the mesenteric lymph nodes and then to the colon, and therefore suppress this activated T cell response. The CD4 positive, CD25 positive Treg cells proliferate and actually directly inhibit these pathogenic effector T cells, which are causing damage to the gut. After the inflammation resolves, what we see in this mouse model of IBD is similar to what we see in people. The CD4, CD25 positive Treg cell population remain in clusters with dendritic cells as well as the pathogenic effector T cells, showing that in the normal state, these Treg cells are actually shutting off the function, inhibiting the pathogenic effector T cells, and that's what they do in normal physiology. Well, this gets us back to the question of how does the immune system recognize an infection, yet recognizes in the gut in particular that the majority of antigens that we are going to encounter are non-pathogenic. And there's a precarious balance between T regulatory cell and TH17 development that probably underpins this important and incompletely answered question. So both Treg development and TH17 development requires the expression of TGF-beta as part of signal 3. So if TGF-beta is required for both T regulatory development, our anti-inflammatory cells, and IL17, one of our most potent pro-inflammatory cell populations, you can see where there's a precarious balance between maintaining homeostasis and the induction of a potent inflammatory response. And what is the difference between whether a Treg is made or a TH17 cell is made? And this may be the presence or absence of infection. In the absence of infection, as we see in the gut normally, dendritic cells make predominantly TGF-beta and very little of another signal 3 required for TH17 development, interleukin-6. In the setting of high levels of TGF-beta, which is produced by dendritic cells and many other cells, as well as low levels of IL-6 and its signal 4 for TH17 development, low levels of IL-23, and naive CD4 positive cells are activated to express FOXP3 and show a regulatory phenotype demonstrated by its ability to inhibit effector T cell inflammatory subsets, including TH1, TH2, and TH17 cells. However, in the presence of an infection with certain pathogens, this induces dendritic cells to express high levels of IL-6. So now the dendritic cells are making high levels of TGF-beta, high levels of IL-6, and begin to make IL-23. And in this cytokine milieu, the naive T cell will not go down an anti-inflammatory route, but will start to express the transcription factor ROR gamma T, and then becomes a TH17 cell, which makes the inflammatory cytokine interleukin-17, which is necessary for host defense against infections, particularly extracellular bacterial infections, through many different mechanisms, including its ability to lead to neutrophil recruitment and development to sites of infection. So let me summarize the T-cell-centric view of inflammatory bowel disease pathogenesis. In the normal state, starting on the left side of the slide, the intestinal mucosa is bathed with bacteria, bacterial antigens, and dietary antigens. But in normal homeostasis, these antigens are processed by dendritic cells and which drive expression of TGF-beta, which lead to mainly a T regulatory state in the gut. There are other factors such as retinoic acid, which has been a highlight of many recent studies, also being important for T regulatory development in the gut. However, in the setting of genetic defects, many of which in inflammatory bowel disease tell us that interactions between bacteria, bacterial products, and host cells of the innate immune system go haywire, we do not get this regulatory milieu, but instead, through the production of IL12 and IL23, we get the development of inflammatory T cell subsets such as T helper 1 and T helper 17 cells, which results in the characteristic inflammation we see in Crohn's disease, which is indeed characterized and shown in human studies to be associated by increased interferon gamma as well as IL17 expression in the intestine. Ulcerative colitis, the other form of inflammatory bowel disease, is also characterized by genetic defects in the IL23 and TH17 pathway, but people have also described a pathogenic T helper 2 signature with increased IL13 levels, so there may be some differences in immunopathogenesis in human ulcerative colitis. Conversely, we have a regulatory T cell response in inflammatory bowel disease that could possibly be defective, but even if it's not defective, it is overwhelmed and isn't doing a good enough job to control the inflammation. So one can think about the pathogenesis of inflammatory bowel disease as overabundance of inflammatory T cell subsets such as TH1 and TH17, particularly in Crohn's disease, or an underabundance or at least a failed T regulatory response. And this is going to be important in terms of thinking of present as well as future therapeutics for inflammatory bowel disease. So let's go from this overview of T cell biology and inflammatory bowel disease to putting on our therapeutic hats. And what are different strategies that we may utilize in the clinic to inhibit the T cell response? And I'm going to highlight three pathways which have already infiltrated the clinic, as well as three pathways where there's going to be many more therapeutic targets and clinical trials to follow. The first pathway that I'll talk about is trafficking of T cells to the gut. T cells that ultimately develop into activated effector T cells and may assume the TH1, TH17, or TH2 inflammatory pathways get to the gut by virtue of the expression of cell surface receptors known as integrins that interact with vascular adhesion molecules, which may be specifically expressed at sites of inflammation or, in fact, on the high endothelial venules of the intestinal tract, leading to egress and specific recruitment of inflammatory T cell populations to the gut. If we interfere with this process, we can theoretically keep inflammatory T cells in the blood vessel and out of the gut. Corticosteroids, one of our mainstays over decades for induction of response in inflammatory bowel disease, have pleiotropic effects on the immune system, but they have also been shown to be able to downregulate integrin and adhesion molecule expression. So one of the ways corticosteroids may in fact work is by limiting cell trafficking, T cell trafficking to the gut. A specific monoclonal antibody known as natalizumab, which binds to the alpha-4 beta-7 integrin, expressed on circulating lymphocytes destined to home to sites of inflammation as well as the gut, is an FDA-approved therapy in both multiple sclerosis and Crohn's disease, providing proof of concept that if we keep inflammatory T cells out of the gut, we may be able to beneficially affect inflammation in IBD as well as other chronic inflammatory diseases. There are several therapies that we think about in use in inflammatory bowel disease that affect the T cell activation process, and the best examples of these are agents such as cyclosporin and tacrolimus, which actually, through inhibiting the transcription factor, nuclear factor of activated T cells, or NFAT, stop IL2 expression from activated T cells, which is a necessary growth factor for T cell activation and proliferation. Other agents that we use more commonly, such as 6-mercaptopurine, azathioprine, and methotrexate, have also been shown to have effects on T cell activation and proliferation. Most relevant to this talk, what can we do in the clinic and what have we done in the clinic to affect the development of T-cell subsets or the production of inflammatory mediators that are produced by various T-cell subsets. For many years, people have regarded anti-TNF as one possible way of targeting T helper 1 cells, as TNF-alpha, the inflammatory cytokine, is a product of TH1 cells, although it's also a product of many different other types of cells, in particular cells of the innate immune system, such as macrophages. So anti-TNF therapy and the successes not only in Crohn's disease, ulcerative colitis, but across immune-mediated inflammatory disorders may be the best proof of concept that we have that the blocking of an inflammatory mediator produced by activated T cells could lead to therapeutic benefit in inflammatory diseases, including Crohn's disease. There are other cytokines which we mentioned, intimately involved in either the differentiation of inflammatory T cell subsets or are products of inflammatory T cell subsets that are very interesting targets in numerous inflammatory diseases. I already briefly mentioned that anti-IL12 P40 antibodies are FDA approved in psoriasis and are moving into later phase clinical trials in Crohn's disease. Anti-IL6 is a strategy that is FDA approved in rheumatoid arthritis with an anti-IL6 receptor antibody and is moving forward in other inflammatory diseases as well. Remember, IL6 is a necessary differentiation cofactor along with TGF-beta for the development of inflammatory TH17 cells. Anti-interferon gamma, for instance, may be a way of inhibiting the TH1 response by neutralizing its most important effector cytokine. So, with that as a brief summary of some of the clinical strategies that we may think about and have thought about to inhibit T cells in the clinic, let me ask you to put on your pharmaceutical hats and to pose a question to you. Which immunologic intervention would not be expected to attenuate TH1 or TH17 responses in Crohn's disease? A, anti-IL12 P40, B, anti-interferon gamma, C, anti-IL6, D, anti-IL13, E, anti-IL17. Well, now that you had a second to think about that, the correct answer is anti-IL13. Anti-IL13 would not be expected to attenuate TH1 or TH17 responses in Crohn's disease. Anti-IL13 is one of the signature T helper 2 cytokines. Anti-IL13 antibodies have been shown to be effective in treating patients with allergic asthma where a TH2 response predominates, and there is some interest in looking at anti-IL13 antibodies in the human inflammatory bowel disease, ulcerative colitis, where at least in a subset of patients a TH2 signal may be evident. In terms of the other strategies, anti-IL12 P40, by virtue of blocking the heterodimeric cytokines which share this common P40 subunit, IL12 and IL23, may be an excellent way of attenuating the downstream TH1 and TH17 response. Anti-interferon gamma, which has also infiltrated the clinic in terms of clinical trials in chronic inflammation, would be expected to block an important TH1 effector cytokine, so this is a way of blocking a TH1 immune response. Anti-IL6, as I briefly mentioned, these strategies are in the clinic, and an anti-IL6 receptor antibody is FDA approved in rheumatoid arthritis, and this may be a way of blocking TH17 subset differentiation, as IL6 is a requisite factor along with TGF-beta for TH17 differentiation. And finally, anti-IL17 would be expected to attenuate the TH17 response as it's one of the important inflammatory effector cytokines secreted by TH17 cells. So, with that review of T-cell biology in inflammatory bowel disease, specifically Crohn's disease as well as other immune-mediated disorders, let's go back to our patient. The patient was discharged from the hospital 6 days following surgery. She remained off of immunosuppressive medications. This is someone with new-onset Crohn's disease who had a relatively short segment resection, and in our practice, we really don't know what her natural history is going to entail. But we do have clinical studies showing that endoscopic recurrence at this surgical anastomosis, which is where Crohn's disease almost invariably will recur following a surgery like this, is predictive of clinical recurrence. So after discussions with this patient, we had elected to leave her off of medications and follow her colonoscopically with the idea if we saw an early endoscopic recurrence, we would initiate immunosuppressive medications. Fortunately for this patient, there was no evidence of anastomotic recurrence 1 year later and on a repeat colonoscopy 2 years later. In the interim, the patient got married, now has a 1-year-old daughter, and is feeling great. Thanks for your attention. I hope this case illustrated some salient features of a new presentation of Crohn's disease, as well as provided a review of T-cell biology focusing on different inflammatory and anti-inflammatory T-cell subsets for you.
Thank you, Dr. Plevy, for a comprehensive and informative case study on the review of T-cell biology, especially how it relates to the pathogenesis of inflammatory bowel disease. This example today really allowed us not only to review the T-cell immunology and its signaling pathways, but also to look deeper into the shared genetic underpinnings of the immune-related disorders, both inflammatory bowel disease and how it might relate to some of the other immune-related diseases such as RA or lupus. And furthermore, we can further think about how to alter these T-cell responses through either T-cell trafficking that you talked to us about or blocking the T-cell activation. And hopefully in better understanding how these potential therapeutic targets such as the IL12-23 that you eloquently laid out for us that's already used in psoriasis and how it can become a possibility in treating other immune-related diseases such as IBD. And hopefully this improved understanding of these mechanisms of these T-cell pathways can be modulated will lead to new insights into both the pathogenesis of IBD and other immune-related diseases, as well as revealing new potential therapeutic targets. Thank you, and we look forward to seeing you in our next T-cell immunology session.